Traditional approaches to suicide prevention have relied heavily on the biomedical disease models, focusing on diagnosing and treating mental health disorders. This chapter and presentation proposes a fundamentally different framework, one that emphasizes personal autonomy, decision-making processes, and individual characteristics rather than just clinical symptoms, particularly to the elderly. The person-centered approach recognizes that suicide in older adults is qualitatively different from suicide in younger populations, requiring distinct suicide prevention strategies. The core insight is that prevention efforts succeed only when they accommodate and fulfill the fundamental human needs for autonomy, competence, and relatedness. When interventions are perceived as threatening self-determination, they fail, no matter how well-intentioned or evidence-based they may be. This framework offers a new lens for understanding why so many at-risk older adults never seek help and why traditional prevention programs often miss those in the most need. Thank you. The demographic profile of late-life suicides in the United States reveals stark disparities that demand attention. Men aged 85 and older have suicide rates nearly 6 times the national average, and among adults 65 and older, the male-to-female ratio approaches 7 to 1, much higher than the 3 to 1 ratio seen in most other countries. White older adults consistently show higher suicide rates than black older adults across the lifespan, though the reasons for this racial disparity remains incompletely understood. Geographic variations are equally dramatic, with the mountain states experiencing suicide rates nearly twice those of the Middle Atlantic region. Beyond these fixed demographic markers, the life circumstances matter. Widowhood dramatically increases risk, particularly in the first 4 years after loss, and lower socioeconomic status measured by education and income consistently elevates suicide risk. These demographic patterns point to a population requiring targeted prevention efforts while reminding us that context, culture, and social structures profoundly shape suicide risk. Physical illness, particularly cancer and chronic lung disease, significantly increases suicide risk in older adults even after controlling for mental disorders. The mechanisms linking physical health to suicide are multiple and complex. Diseases may have direct pathophysiological effects on brain function, but psychological factors are equally important, if not more. Functional impairment, chronic pain, and loss of independence creates what researchers call psychological burdensomeness, found usually in the interpersonal theory of suicidal behavior by Thomas Joyner, the feeling of being burdened to others. The terror of suffocation and lung disease, the loss of control over bodily functions, and the anticipation of disability all contribute to existential distress. Critically, older adults who die by suicide are far more likely to have seen a mental health specialist in the weeks before death, yet these primary care visits often fail to identify suicide risk. This reality demands that we understand not just the physical conditions make themselves, but how patients and physicians make decisions about discussing and addressing mental health concerns in the context of serious medical illnesses. Research reveals a paradoxical finding. Older adults who die by suicide often appear more psychologically healthy than those who survive suicide attempts. They tend to be lower in neuroticism, more conscientious, less emotionally volatile, and more achievement-oriented. British researchers describe them as social individuals who were determined to soldier on unaided, who practice deliberate concealment of their distress from others. These personality characteristics create a perfect storm for missed prevention opportunities. Their shy reclusiveness reduces social contact. Their avoidance of novelty keeps them away from mental health services, and their tendency to minimize symptoms makes them difficult to identify even when they do see healthcare providers. Personality traits don't just increase risk for developing mental disorders, they fundamentally shape how people detect their own symptoms, whether they seek help and how they interact with healthcare providers, and whether they adhere to treatment. Understanding these variables is essential because they represent temporally distal risk factors that unfold long before acute suicidal crises develop, offering potential intervention plan points that currently approaches miss entirely. Primary prevention targets entire populations rather than individuals with identified risk factors, focusing on health behaviors and environmental modifications. Successful examples include medication packaging mandates like blister packs that makes overdosing more difficult, though more controversial interventions like firearm restrictions and bridge barriers face significant political opposition. The Gotland study in Sweden trained all primary care physicians in depression detection and treatment, achieving a 60% reduction in suicides, but only among women, and only while the program continued. Similar patterns emerged in Japanese community mental health programs and Italian telephone support services. Significant reduction in suicide among older women with minimal effects or no effects among men. These different outcomes by sex represents one of the field's most vexing mysteries and suggests that current primary prevention approach fails to address fundamental barriers to help seeking among men. The question isn't whether primary prevention can work, it clearly can, but rather how to design interventions that reach populations most at risk, particularly older men who are disengaged from healthcare systems. Primary prevention faces structural, political, and philosophical obstacles that severely limit its implementation and effectiveness. No federal agency in the United States is devoted to primary prevention. Instead, institutions are organized around specific diseases and procedures, reflecting a fragmented approach that Douglas calls a consequence of bureaucratization. The initiatives often conflict with deeply held values about individual liberty and autonomy, leading critics to view them as paternalistic social engineering. When preventionists propose interventions like firearm restrictions, they trigger emotional resistance because liberty and property and self-defense all feel threatened, and prevention advocates have failed to craft a compelling narrative that anticipates and addresses these effectively charged concerns. Beyond political opposition, primary prevention faces another practical limitation. Interventions requiring active decision-making consistently fail to reach those most at risk, as demonstrated by studies where half of isolated seniors declined repeated offers of help. The fundamental challenge is that behaviorally oriented primary prevention asks people to make proactive decisions about health in ways that feel counterintuitive and potentially threatening to autonomy, virtually guaranteeing them that those most in need, the disengaged and disenfranchised, will never participate. Secondary prevention targets individuals with identified clinical conditions, primarily depression, using screen-based instruments and evidence-based treatments. The prevention of suicide in primary care elderly collaborative trial and similar studies have shown that collaborative care models combining medication and psychotherapy that can reduce suicidal ideation more effectively than usual care. Dialectical behavior therapy, cognitive behavioral therapy, and interpersonal psychotherapy all show promise in reducing suicidal thoughts and behaviors in older adults. However, a critical limitation undermines the entire secondary prevention enterprise. No study have demonstrated that any treatment actually reduces suicide mortality. All the evidence concerns surrogates endpoints like ideation or attempts. This isn't because treatment don't work, but because the low base rate of suicide makes it statistically challenging to conduct adequately powered studies. As researchers note, true monumental segments of personal time are needed to achieve adequate statistical power. The ethical prohibition against withholding potentially effective treatment from suicidal individuals further complicates randomized trial designs. We're left in the uncomfortable position of implementing treatments that seem reasonable and reduce symptoms, but without definitive evidence that they prevent the outcome that matters most: death by suicide. Secondary prevention fails to reach the populations at higher risk and imposes approaches that threaten the autonomy of both patients and providers. At-risk older adults, particularly men and those of lower socioeconomic status, are fundamentally reluctant to seek mental health treatment, and many cannot afford quality services even when willing. Depression screening, the cornerstone of secondary prevention and primary care, is undermined by personality factors. The habitual non-confiders, who are at most at risk, systematically underreport symptoms on standardized treatments. Manualized of treatments, while evidence-based, have been researched for reducing clinicians to research assistants and eliminating what we initially sought in our professional lives, our patient voices. Primary care physicians express skepticism about screening instruments and feel their professional autonomy is being eroded by third-party mandates. The tragic irony is that tools designed to identify and help at-risk individuals, screening instruments, and standardized treatment are precisely what prevents the most vulnerable from being reached and what alienates the provider who might help them. As Barry Lebowitz predicted, even successful multi-component interventions demonstrated in research settings are unlikely to be feasibly implemented in real-world American healthcare, not because they don't work, but because they don't fit how care is actually delivered or how people make decisions about seeking help. Person-centered primary prevention succeeds by being invisible, unintrusive, and unthreatening to self-determination. The ideal examples are libertarian and paternalist interventions like blister pack medication packaging. Nobody gets emotional about prying tablets from foil rather than pouring them from a bottle. Yet the simple modification reduces overdose deaths. These interventions nudge people toward healthier choices without restricting liberty or requiring active decision-making, making them politically viable and practically effective. In contrast, interventions that feel threatening, like firearm restrictions, generate intense emotional and political resistance because they appear to take something away and threaten core values of liberty, property, and self-defense. The person-centered critique reveals why some primary prevention efforts stall. Advocates fail to anticipate the effectively charged environment and craft compelling narratives that acknowledge rather than dismiss autonomy concerns. Bridge barriers face opposition not because they're ineffective, but because advocacy groups see them as wasteful intrusions, and preventionists haven't successfully marketed them as enhancing rather than restricting freedom. The lesson is that primary prevention must either be so benign as to be unnoticeable or must be presented through marketing and communication strategies that build public support by explicitly addressing autonomy needs rather than dismissing them as obstacles to overcome. Person-centered secondary prevention replaces depression screening with psychosocial assessments that enhance rather than threaten autonomy and competence. Interactive multimedia computer programs in primary care waiting rooms could assess personality traits, values, and health beliefs in ways that feel less invasive than depression questionnaires while providing richer information about suicide risk. These assessments would use items-response theory to calibrate questions to individuals' traits and accounting for the systemic underreporting that occurs in social, non-confining patients. The benefits extend beyond suicide prevention. Psychosocial assessments convey that quality healthcare involves understanding the whole person, not just ordering tests and prescribing medications. They offer providers a structured way to relate to patients as individuals while respecting professional autonomy by supporting rather than supplanting clinical judgment. Tailored communication strategies could use assessment data to persuade reluctant patients to discuss suicidal thoughts with their doctors, addressing the fundamental problem that most at-risk individuals are least likely to disclose. The infrastructure required for computerized tailored assessments represents a substantial investment, but cost offsets are likely favorable given the multiple benefits for patient-centered care, provider satisfaction, and prevention of multiple adverse outcomes beyond suicide. One of the suicide prevention's most troubling paradoxes is that women more frequently engage in suicidal behavior, while men more frequently die by suicide, yet nearly all successful prevention programs work for women but not men. The Gotland Physician Training Program, Japanese community interventions, and Italian telephone support all achieve significant suicide reduction in older women while having minimal or no impact on older men. This consistent pattern points to fundamental barriers to help seeking among men that current interventions fail to address. Physicians are less likely to recognize and diagnose mood disorders in men than in women for reasons that remain poorly understood. Traditional masculine norms may conflict with help-seeking behaviors and with the vulnerability required to engage with mental health services. The person-centered framework suggests that prevention approaches designed primarily for women may inadvertently threaten the autonomy needs that are particularly salient for many men. Until we understand why community-level programs that reach successfully and help women consistently fail with men, we cannot claim to have effective population-level suicide prevention. This gender paradox demands urgent research attention because it represents our single greatest prevention failure in the population at the highest risk. Technology offers unprecedented opportunities to reach disengaged populations before they develop acute suicide risk. Interactive multimedia programs and primary care waiting rooms could use tailored persuasion strategies to encourage patients to discuss their psychological concerns with their doctors, customizing messages based on individual personality profiles and values. Social networking platforms and telecare support systems could provide ongoing connections for isolated older adults, though research is needed to understand which patient characteristics makes individuals well suited for technology-based interventions versus those requiring human contact. Electronic redesign of primary care offices could seamlessly integrate psychosocial assessments into routine visits, making mental health evaluation as routine as measuring blood pressure. Research priorities include developing interventions that enhance rather than threaten provider autonomy, using items response theory to create personality calibrated screening instruments, and most urgently, solving the male suicide paradox. The fundamental principle underlying all future direction is temporal. We must identify and intervene on risk markers long before individuals develop mental disorders or reach suicide crisis, because by that point opportunities for prevention have largely passed. Creative methods for enhancing risk detection, treatment initiation, and adherence must be developed with the recognition that those most at risk will never voluntarily appear in our offices seeking help. Thank you for watching this video. The central argument of this video of this person-centered framework is that standard biomedical and behavioral approaches, while necessary, are fundamentally insufficient for preventing later life elderly suicide. Many older adults at highest risk will never enter mental health treatment because of personal characteristics that make them reluctant help seekers, structural barriers that limit access, or attitudes that prevent them from recognizing their own distress. Prevention must therefore reach beyond clinical encounters to address decision-making processes at multiple levels. Individual traits and motivations, provider or characteristics, and clinical interactions, and organizational and political structures that shape how prevention sources are allocated. The person-centered approach isn't anti-treatment or anti-screening. It simply insists that all interventions from individual to public policy must accommodate fundamental human needs for autonomy, competence, and relatedness. When prevention efforts are perceived as threatening self-determination, they fail, regardless of their evidence-based or good intentions. Success requires all stakeholders, patients, family providers, and families themselves in ways that enhance rather than undermine their autonomy and perceived competence. The ethical imperative is clear. We must create approaches that meets the need of all, not just those who happen to seek our help, because the most vulnerable are precisely those who never arrive at our doors. Thank you again once more for watching this video.